Hello, welcome back, everyone. We now have time for a panel discussion, which will include addressing some specific comments that came up during today's 4 talks. I will encourage all of you to still continue to use the Q&A function on the meeting platform to send us additional questions, which could be specific for any of the 4 talks or general questions for our faculty panel. At the outset, let me say that unfortunately, Dr. Del Rio was called away and is not available currently. He hopes to be able to join us later in the panel before we have to close, but he is not with us at present. So I'm going to start with some of the questions that already came in on the Q&A in the platform, and I'll try to address them in the order in which they were submitted. So the first question I think is largely for me, and that is whether the LS modification reduces effector cell function. It's actually an excellent question. As far as I'm aware, the LS modifications do not alter effector cell function. I believe that's because the FC receptor involved in effector cell function, particularly antibody-mediated cellular immunity, it's a different receptor, but I'll have to go check that. I think it's not the neonatal receptor. I think it's a different receptor. And Marina or Dan might know the answer to that.
Yeah, Charlie. So the way that the LS modification works is by increasing affinity for the neonatal FC receptor, it leads to recirculation of antibody. So when antibody is taken up through endocytosis or receptor-mediated binding into the cells, instead of being targeted for degradation, they get recycled and re-excreted by the cell, and that is what effectively leads to a prolonged half-life. But that shouldn't have an effect on effector function, so far as I'm aware.
Thanks. That was my understanding. Marina, I don't know if you want to add to that.
Yeah, I'll just add that so there's a whole other family of FC receptors that will have effector functions, and there are modifications that are being introduced to monoclonal antibodies to enhance effector functions. And then we didn't get to talk about this here, but for example, there is an antibody for hepatitis B where these modifications to enhance effector function have been introduced with the hope that the antibody will then not only be able to clear replicating virus, but perhaps directly target infected cells. So modifications can be done in different ways to modify, to enhance certain aspects of antibody activity.
Okay, great, terrific. Let me move on to a question for Dr. Mazur. The question is about resistance and whether you think it's possible that there are chances that respiratory syncytial virus will escape neutralization by the new extended duration monoclonal antibody nirsevimab. So I don't know if there's been resistance reported in clinical studies of that antibody, or if you think it's possible.
Yeah, I think it's an excellent question, kind of the $1 million question that we'd all like to answer, but I think I can give some direction. So there have been nice publications on monoclonal antibody resistance viral mutants. which has been quite well characterized for nirsevimab. So there are mutations that we know that can give complete resistance for both RSV-A and RSV-B. But the question is, how often do these mutations occur in clinical isolates, and are these viruses fit, yes or no? And as far as we know now, so there's a very big study, INFORM, occurring in more than 20 countries worldwide, where we're characterizing genetic sequences of RSV. It seems that these mutations occur very infrequently. So I would say I don't expect a lot of viral resistance to occur. Monitoring will occur on an ongoing basis, so after implementation of nirsevimab. And what we know from palivizumab is that after 20 years on the market, there was little to no resistance to palivizumab. On the other hand, for subtavumab, which I mentioned briefly in my talk, there was complete resistance against RSV-B strain. So we do know sometimes that resistance can occur. That was a site 5 monoclonal. So I think we're quite hopeful, but we still don't know for sure whether resistance will occur. And maybe in the end, a cocktail of monoclonals will be the real solution to stop RSV. Thanks.
Just to follow up on that, it is fascinating that there's been no resistance to palivizumab. Do you think that's because resistant mutants greatly lose their infectious capacity or fitness in some other way? Or do you think there's another explanation for why that antibody does not seem to select for resistant variants?
I have to say I'm not sure, but it doesn't sound, I'm fairly certain that resistance mutations against palivizumab are not less fit viruses. So I don't think that that's the correct explanation. I'm not sure we know why. And yes, it's very interesting. I agree. One aspect that may contribute is that for the fusion protein of RSV, there's a unstable pre-fusion protein and a more stable post-fusion protein. And the site that palivizumab binds to is on the pre and the post-fusion protein. So maybe the fact that it actually targets something that's on multiple epitopes of the virus, that might be the reason. And this is, I'm kind of contemplating the reason because I'm not sure we really know. So that might be an explanation. To me, that's the most viable explanation, actually.
Okay, great. Moving on then, another general antibody-related issue that's come up is the whole question of anti-drug antibody responses. And to the extent it happens and to the extent it affects the efficacy of monoclonal antibodies for treatment and prevention of infectious diseases. There was a specific question about the nirsevimab main trial in which autoantibodies were tested, seemed to reduce the efficacy only modestly from 180 to 360 days, but not prior to 180 days. So rather modest impact there. But I wonder also if Dan and Marina would like to comment on the development of anti-drug antibody responses with human monoclonal antibodies like the broadly neutralizing antibodies for HIV. So I think this is a question that the entire panel should be equipped to respond to.
And I can start, and then Marina can add additional perspective. The the one monoclonal antibody that's been used and is now actually FDA approved for treatment of HIV is really a humanized murine antibody, which is ibolizumab. That is an antibody that is dosed every several weeks. And in the phase 2 trials, there were antibodies that developed, but they didn't seem to have an effect on the efficacy of ibolizumab. That's different from, and that of course is not an HIV-directed antibody, it's directed against CD4. But that's very different from human bNAbs. There haven't been multiple administrations beyond, not, there've been a few administrations, but not chronic administration of HIV bNAbs. So the availability of evidence right now is somewhat limited, but Marina has the greatest experience with this, so she should really comment.
Yeah, and so with the bNAb, so the fully human antibodies, what has been seen is that there may be induction of transient antibody responses against the monoclonal, but to date, there hasn't been any data showing that it affected the pharmacokinetics or the activity of the antibody. However, as Dan mentioned, none of the studies have been long enough. The AMP study, where the antibodies were given over the course of 18 months, is probably the longest exposure. It'll be interesting also to see what happens, I think, with these LS modifications that are going to have a very slow decay, a very long tail. Will that be more triggering of ADA? I don't know. And for sure, some of these antibodies have also been modified to be bispecific or even trispecific. And the further that away from looking like a regular antibody they become, maybe we'll start seeing more of this anti-drug antibody responses. So we just have to see what the longer studies will show.
Yeah, on that point, I can say that there is an ACTG trial of the first prototypical trispecific bNAb that is just wrapping up, and so data should be forthcoming from that trial in the next several months.
Okay, terrific. There is a question about antibody combinations. So there's a question that says, it seems that to assure broadly neutralizing antibodies stay continuously efficacious, there is a need to combine them. That might not be sustainable in the long run. What are the risks for that, and what can be done to help prevent that? And I would add that this seems to apply to COVID as well, where attempts were made to combine broadly neutralizing antibodies to overcome the rapid mutation of that virus, which had only limited efficacy. So how many antibodies and how long are we going to have to be doing this? Is this really just chasing our tail to try to avoid the emergence of resistant variants?
Well, I think I think there are a couple of different aspects to that important question. So, the first is getting adequate coverage. And as I tried to illustrate briefly in my talk from the terrific analysis that Wog et al. Published several years ago, to get several antibodies, each of which provide high levels of coverage, is very challenging, even if you're using 3 antibodies in combination. The question will be, if you combine a couple of antibodies or even one antibody with a potent small molecule that is also long-acting, could you sustain suppression without having to necessarily cover broadly all viruses? I think that's a challenge, because the currently available long-acting agents are themselves at risk for developing resistance or selecting resistance, including both cabotegravir and lenacapavir. The second, I don't think there's a true risk to the participant or the patient, except for potentially volume if it's multiple administrations and somebody has tenuous cardiovascular status. It's more of a logistical challenge and a challenge in terms of cost of goods. That is, since it's expensive to manufacture antibodies, unless these antibodies can be formulated to be combined in a single infusion, then it's a logistical challenge. And of course, it's very expensive. And that's why people are looking at bifunctional and trispecific antibodies as a way of being able to have multiple specificities in a single molecule, but that has its own challenges.
Marina, I'm sure you have an opinion about this, and would love to hear
I wanted to ask Dan a question, like a virology question. Do you think we would be able to find the right combination of anti-envelope antibodies that the virus could still escape but be so unfit that it could, which goes back to the point earlier about RSV, that it would no longer replicate enough?
Potentially, I think we've certainly seen evidence with protease inhibitor resistance and with 3TC resistance is the model here, where you end up with a virus that has a severely impaired replication capacity, where the reduction in replication had clinical benefit for patients. But whether, envelope is so variable, and we've been surprised so many times, even, with ibilizumab that doesn't target the envelope, you still get mutations that emerge that allow the virus to find a different way of using CD4.
It seems that the virus can tolerate all sorts of mutations on the envelope, right, and still finds a way to infect.
I have to confess, to me, the most remarkable thing about this whole area of antibody resistance is the circumstances in which monoclonal antibodies retain in which the targeted pathogen retains its sensitivity to a monoclonal antibody essentially indefinitely. And we have an example of that with respiratory syncytial virus. But, I think it's also true that we have similar situations, perhaps with malaria now, and some of the antibodies for Ebola. Any insight as to why some of these applications do not seem to promote selection of resistance and others do? Dr. Mazur, maybe you could answer that.
Yeah, well, I think a very simple answer is how fast a virus mutates. So we know that RSV is pretty stable. I don't know about malaria parasite, how stable that is. And RSV is quite simple. So I think that may have something to do with it. Although in the field of RSV, we also have some strange example of a very targeted monoclonal, which failed in phase 3 of development, while we were totally not expecting that. So I'm not sure we really have the answer, but I think a part of it at least, and I'm curious what Dan thinks about this, but that part of it is intrinsic to the virus and how fast it mutates, and whether the mutations at that site end up in a virus that has a reasonable amount of fitness, yes or no?
Yeah, I think that's right. And as I touched on briefly in the talk, it's a combination of what is the intrinsic mutation rate of the viral polymerase, plus what are the numbers of rounds of replication that you have and the opportunities to accumulate a mutation. And so with a wildly spreading virus like SARS-CoV-2, despite having a relatively high fidelity polymerase with a proofreading function, no less, we've seen extraordinary diversification of the virus because there's so much selection that occurs with each transmission. I think, just to be clear, there's no evidence whatsoever that the mAbs developed for, the monoclonal antibodies developed for COVID-19 had nothing to do with the emergence of these variants. The variants emerged because of naturally occurring immunity in populations, and perhaps driven a little bit later on by vaccination as well. But certainly within individuals, you could see a resistance emerge if particularly when only a single active BNAb was given, you could get resistance to the other BNAb. That's work that Manish Chaudhry and Jonathan Lee showed with the VRI antibodies.
So there is another question related to susceptibility testing for broadly neutralizing antibodies, or really I would say susceptibility testing for monoclonal antibodies in general. The question says, what does susceptibility testing involve? And Marina and Dan, maybe I could throw that out for you to explain what susceptibility testing involves and why it is so complicated, and then maybe ask the entire panel about the potential value of susceptibility testing in circumstances where there may be pre-existing resistance to a monoclonal antibody for an infectious agent. So Marina and Dan, what does it take to assess susceptibility testing to an HIV broadly neutralizing antibody?
So, right now, the one assay that has been developed for that can be applied in clinical use, or to assess participants for entry in clinical trial, it's a phenotypic assay, but it requires amplification of the envelope to build a tool in the laboratory that is called a pseudovirus. So it's a virus that expresses envelope sequences that have been recovered from a person with HIV. And these now reagents are tested in another layer of the assay to see if it can block infection of cells that are susceptible to HIV infection. And you want to see if you add different antibodies and it blocks the pseudoviruses that have the person's envelope, that blocks infection of the cells, then you can do titration and then define if those viruses are sensitive or resistant to antibodies. So it's a very labor-intensive method, although it is the method that is used for testing for CCR5 usage. So that the platform has been in existence and has been in clinical use for years, since Maraviroc has been in clinical practice. But it is a multi-step, intense assay. The challenge comes when you are in a situation where you don't have access to plasma viruses. And what you have to do is you have to collect cells, so CD4 T cells that harbor HIV in someone who is on suppressive ART. And then you can recover these proviruses, so viruses that are integrated in the T cell, and then create the same library of pseudoviruses. But the question that one has to ask is, can we really represent well enough what's archived in the reservoir if we know that the number of T cells that harbor HIV during ART, these cells are rare. So when you get a blood sample collection, you're probably going to have only a few CD4 T cells that have HIV, and then you're going to recover the envelope from those cells. But are those envelopes really representative of all the viruses that one individual harbors in the reservoir? And we don't really know the answer to that. So the assay in itself works very well. The question is, if the readout that you have, how representative it's really going to be of what's maybe archived in that one particular individual. Then do you want to give it a more eloquent virology?
Yeah, no, I agree with everything that Marina has said. I would add that even when you're starting with a plasma sample, the success of the assay is not guaranteed. It's well tuned to subtype B viruses, but it doesn't always generate results with other viruses. In a study that Roger Shapiro, Matthias Lichtenfeld, and I are doing, that we presented results at CROI, I think initially a year ago, we had where infants or now toddlers were getting bNAb therapy after being suppressed on small molecule treatment, and then the combination ART was stopped, and about 60% of the babies had rebound. So they had adequate plasma virus, but we were successful in obtaining phenotypic results from this assay in only about half of those cases because of amplification failure. When we sent single genomes that we had amplified with subtype C specific primers to the lab for testing, they were then able to get the phenotype. But that's obviously not going to be clinically practical. I think it is an issue, with some of these clinical trials that are underway now. For example, there's one study that's going to be done with cabotegravir and N6LS. I would think you'd want to know if the person has susceptibility to N6LS before placing cabotegravir at risk. Because if you fail and then generate integrase inhibitor resistance, that's a big problem. In the study of lenacapavir plus the 2 bNAbs, they started out by screening over something like 150 or 170 people to eventually end up with 20 participants who were able to get the combination bNAb plus one, and so that's a big challenge right now.
Okay, there is an interesting question for Dr. Mazur. Could you please comment on the feasibility of passive administration of bNAbs to infants to prevent vertical transmission? Well, actually, this is the HIV question. Could you comment on the passive administration of bNAbs to infants to prevent vertical transmission of HIV? I guess that's a combined pediatric and HIV question.
I wanted to quickly, before I go on to your question, which I'm not sure I'm the best person to answer, but I wanted to add something briefly to the characteristics of monoclonal antibody resistant viral mutants, that there's some really interesting work happening at the Fred Hutch Center by Jesse Bloom, who's developing, using computational biology, a high throughput method of characterizing MARMs and characterizing their fitness and their evolution. So that's there's some interesting development. I don't know all the details, but I know he's been doing some really cool work. So I'm sorry, I don't think I understand the question exactly. So the question.
Yeah, the question was passive administration of broadly neutralizing antibodies to infants to prevent vertical transmission of HIV. But I guess there's a related question for you about the use of anti-RSV monoclonal antibodies strictly in a prevention setting rather than a treatment setting.
Well, actually, so all monoclonals, maybe that wasn't clear. All monoclonals for RSV currently are really being used in a prevention setting and not in a treatment setting. And for RSV, we know, well, I guess there's been it's a bit of research showing possible vertical transmission, but I think generally the consensus is that there's no vertical transmission of RSV antenatally or postnatally. And the reason that monoclonals or broadly neutralizing antibodies, which have also been approved for RSV, are used as prevention and not treatment is because you're often too late with treatment. So there's been too much viral replication. Only in the case of some cases of children with stem cell transplantation and immunodeficiency is it still administered as treatment, for example, palivizumab, but there's no good evidence of antibodies for treatment instead of prevention. So I turned the question around, but I hope that's a sufficient answer.
Yeah, I could just point out that there's a long history of using immunoglobulin therapy in neonates to prevent transmission of hepatitis B before hepatitis B vaccine became widely available, at least in the United States, not around the world. It was standard practice when you knew that there was a hepatitis B virus positive mother, that you would give hepatitis B immune globulin together with vaccine to prevent vertical transmission of hepatitis B. And in the pediatric AIDS clinical trials group, now the IMPACT network, there was many years ago a study of HIV immune globulin to prevent mother-to-child transmission. And more recently, there have been studies giving mAbs to neonates. So it's certainly eminently feasible to administer. I think the bigger challenge would be demonstrating efficacy, especially in the context where you have proven efficacy of antiretroviral therapy. You would really be asking, does giving, in the case of HIV, does giving an HIV bNAb improve protection against transmission, or you would be focusing on late presenters who may not have been on antiretroviral therapy because they were undiagnosed or not in care prior to delivery. But there's no barrier, to giving the antibodies to neonates from a clinical perspective.
That's an interesting observation, Dr. Mazur, about the failure of monoclonal antibodies to treat active RSV disease. Mm-hmm. The assumption being that if you administer the antibody to someone who's already got a lot of replicating virus, that there's not enough antibody to bind the amount of virus in the infected infant. But could you overcome that by giving a higher amount of antibody, or is there another explanation as to why there doesn't seem to be any clinical benefit at that point? And this would be in contrast to the Ebola situation I discussed earlier, where there is clear clinical benefit, depending upon the antibody or the antibody combination, to treating after the onset of symptomatic disease.
Yeah, so I think we know that symptoms start about 3 to 4 days post-infection for RSV, and then max viral load is between day 3 and 7, more or less. But I think maybe it has to do with the pathophysiology of RSV infection. So for small children, part of the reason that they have respiratory failure or end up needing oxygen is because the smaller airways, especially in children under 1 year of age or under 2 years of age, that they become, to put it really simply, full of snot. So that means that your immune reaction against RSV actually is part of the pathophysiological problem. And probably that mechanism is already ongoing by the time you get symptoms. So if you were to use treatment on day 3, it wouldn't help anymore because you already are producing too much snot and your airways are full of mucus and neutrophils especially. And you won't stop that with a monoclonal because you already have your max viral, reached your kind of max viral load. So I think you might stop further viral replication, but it won't have a clinical effect. And I'm not sure how it works with Ebola, but probably differently. And that's probably a good explanation.
Okay, great. There's an interesting question about combining monoclonal antibodies with small molecule anti-infective agents. So this question starts out with the SARS-CoV-2 example. It says, do you see any advantage of combining anti-SARS-CoV-2 monoclonal antibodies with antivirals like Paxlovid or Molnupiravir? And I guess it would depend, first of all, on whether or not it was a monoclonal antibody that had activity against the virus variant with which the patient was infected. But would that have made any difference in, Dan, you think in the various monoclonal antibody studies for SARS-CoV-2?
Well, I think certainly if somebody has received a monoclonal antibody and then has progression of disease, that it would then make sense to treat them with an antiviral, but whether that would still be Paxlovid or whether it would be remdesivir, I think would depend on the setting, since nirmatrelvir, ritonavir is intended for use in symptomatic outpatients with mild to moderate disease. So if you've gotten a monoclonal antibody if you got a monoclonal for prevention and you got symptomatic disease, then absolutely I would still treat with nirmatrelvir, ritonavir, or potentially molnupiravir. If you had gotten an antibody for symptomatic disease and now ended up hospitalized, I'd treat with remdesivir because that's the indication for remdesivir treatment. I don't see an advantage to giving a combination of treatments. There have been discussions about whether combination antiviral therapy would prevent relapse in those people who are having a relapse after getting an antiviral. To date, there's very little evidence that resistance is contributing to that relapse, and so I don't see much benefit to combining the two modalities right now.
Okay, great. I see that Professor Del Rio has joined us. Terrific. Welcome, Carlos. There is a follow-up question that I think would be appropriate for Professor Del Rio. And the question is, why are some monoclonal antibodies only licensed for prevention? Will they still work as a therapeutic add-on, for example, in heavily immunocompromised patients? Dr. Mazur started that conversation a little bit with respect to RSV. But what about the issue of licensing for prevention versus treatment? If an antibody is only licensed for prevention, should we be using it for treatment, and vice versa? If it's licensed for treatment, would it be just as valuable in a prevention setting?
Well, thank you, Charlie. I think it depends on the setting, and depends on the antibody, and depends on the mechanism of action. Clearly, first of all, let's start by saying in HIV, neither treatment or prevention, no monoclonal antibodies have been licensed for either treatment or prevention. They have been used for treatment or prevention studies, but at this point in time, none of them has been licensed. But you could potentially say, yeah, if something works at one level, could you try it on the other? Absolutely. I think that's part of the strategy. In COVID, we had antibodies that were licensed for treatment, and one antibody that was licensed for prevent, or was at least was given an EUA for two antibodies were giving EUAs for prevention. I think that in COVID the data was much more clear, but I think both in COVID and HIV, what we're seeing is that what we saw in the AMP study in HIV is the viral diversity so wide that I think that the lesson here is that at least in HIV, one antibody is not going to be sufficient. You're going to need a combination of antibodies. And that combination of antibodies or antibody cocktail, how to put it together, I think is going to be the really important sort of point. I think as Dan presented, we were very excited to hear at CROI this study presented by Joe Aaron about using, lenacapavir with two long-acting monoclonal antibodies. That's a really incredible strategy. I mean, when I think about that, if you can give somebody a pill in 2 injections every 6 months and control their HIV, man, that's fascinating. Could you also do something similar for prevention? Yeah, I think it'll be certainly possible, right? I mean, I think the AMP study was about prevention, so it'll certainly be possible. But what we learned in AMP is that only the strains that were susceptible to the antibody were prevented, and those were very few and far between. So I think at the end of the day, we will need multiple antibodies for prevention, and the reality is infusion of antibodies for prevention, even every 6 months or every year, for wide segments of the population for prevention of HIV is simply not going to be a viable strategy, at least in this point in time. I don't know what you think, Dan.
Yeah, I think that the costs and logistics of doing that on a global scale would really be daunting unless there were dramatic improvements in the efficiency of manufacture, or something like vectored delivery, where instead of giving the actual antibody, you're giving a recombinant virus that would then make the antibody and do so on a prolonged basis. And there are people that this concept was started by David Baltimore, but there are people like Alex Balazs at the Reagan Institute and others who are, and Mike Farzan and people who are actively exploring this strategy.
Okay, there's a question about cost effectiveness of monoclonal antibodies, and maybe this is a good topic for the entire panel, but the question specifically says, is the use of monoclonal antibodies for treatment of infectious diseases more economic than drugs in the same condition? So let me, Carlos, since you just joined us, and you mentioned that in your talk, let me ask you to respond to that issue. Can we ever make monoclonal antibodies cost effective for the prevention of a disease like HIV?
I think for HIV, it's going to be really hard to come up with a when I think about the current cost of generic, TDF FTC for HIV prevention, I think it's going to be really hard to get below that cost for, if you want to talk about PrEP at a global scale, to get that low a cost. That doesn't mean it's impossible. At some point in time, 10 years ago or 15 years ago, all of us would have said dolutegravir FTC, 3TC is going to be impossible to get to less than $1 a day, and yet that's where we have it right now available in PEPFAR, right? You get get TDL for an incredibly low price. So I think prices in global therapy of HIV have come down in an incredible way in therapeutics, and I guess that could happen also in monoclonal antibodies, but I don't think it's going to happen right away. I think it's going to take a long, long time to get there. So in HIV, the answer I think is no.
And then Dr. Mazur, let me ask you to comment on that. It's obviously a more cost effective to use a monoclonal antibody for prevention than a drug if you don't have a drug, as is the case with RSV. So I guess there are a couple of drugs that have been used that have activity, but that have been largely abandoned. But what about in the circumstance where you only have a monoclonal antibody?
Yeah, actually, I think the question is a bit in the field of RSV. So there are two big questions in terms of cost effectiveness. There's the question of a maternal vaccine, which has the same kind of mechanism where you induce protective antibodies, maternal protective antibodies, which then are transferred to the infant and passively protect the infant, versus a monoclonal. And initially, it has been thought that maternal vaccines will be much more cost effective. They're less effective generally, but they're more cost effective because they're much cheaper than monoclonal antibodies. So that's kind of a simple, and just last week in the New England Journal, the phase 3 results of a maternal vaccine were published. So we can expect registration quite soon of the maternal vaccine. So if you look at cost effectiveness between those two, then generally maternal vaccines are more cost effective, but the more important debate, as far as I'm concerned, is cost effectiveness in lower middle income settings, which is where I devote all of my research actually. And for RSV, which on some level is similar to HIV, I guess, in that sense. So RSV is a problem around the globe. As a pediatrician in training in the Netherlands, we see RSV every day, and the ICUs are full of children with RSV in the winter months, and the pediatric ward as well. So it's a big problem, but there's almost no deaths due to RSV, probably because we're able to provide respiratory support in lower middle income countries. So we know that RSV is the second cause of death after malaria for infants, and 99% of mortality occurs in the developing world. And so for me, if we're talking about cost effectiveness, it's important to look at cost effectiveness in the developing world, and that's very challenging for monoclonals, although there are efforts on behalf of Gates MRI, so that's a non-profit biotech from the Gates Foundation, to the $4 mark for monoclonals so that they may become cost effective in LMICs. And there's currently a monoclonal being developed, which is actually super similar to nirsevimab by Gates MRI, and it will enter phase 2 probably soon, or at least they just finished phase 1.
Well, on that note, I think we're going to have to end as we have reached the end of our allotted time. And there were several questions we were not able to get to. So I apologize to the audience for the fact that we didn't have time to respond to all of your questions, but it is indicative of the excitement and the interest in this field. And clearly we have a lot more to discuss at future workshops.